Good afternoon, everyone. What a pleasure it is for me to introduce Dr. Vivek Goel. He is the University of Waterloo's 7th President and Vice Chancellor. He is a distinguished scholar with extensive achievements in research, teaching, and leadership across both public and private sectors. We're so thrilled to have him as our President and Vice Chancellor at the University of Waterloo. Dr. Goel is recognized in Canada and around the world as a leading public health researcher, a health services evaluation expert, and a champion for the use of research evidence in health policy making. He's held a number of senior leadership roles in a variety of agencies at the University of Waterloo, including as Vice President and Provost, and most recently as Vice President Research and Innovation, where I had the pleasure of interacting with Dr. Goel before he came to Waterloo. He served as founding president and CEO of Public Health Ontario from 2008 until 2014. He served on the National COVID-19 Immunity Task Force and is the chair of the Expert Advisory Group on the development of a Pan-Canadian health data strategy. Professor Goel is a fellow of the Canadian Academy of Health Sciences, a fellow of the Fields Institute for Research in the Mathematical Sciences, and a member of the Order of Canada, among all his other awards and accomplishments. Such a pleasure to have you here today, and we're really looking forward to your talk, Vivek.
Thank you, Charmaine, for the kind introduction. And it's a great pleasure to be kicking off this conference that we're doing jointly with our colleagues at CIGI. And I'm looking forward to the deliberations. As Charmaine noted, I am also the chair of the Expert Advisory Group on developing a Pan-Canadian health data strategy. And I'll be speaking to you about the work that our group has been doing. We were established in the fall of 2020 with a view to helping all of Canada look at how we have handled data through the COVID-19 pandemic and what we can do to make sure things are better in terms of equipping Canada to be ready for future public health threats, but more generally for issues related to the health system writ large. So, I think in terms of the motivation for doing this, I don't have to rehearse a lot for this group. The headlines that we've seen throughout the pandemic on various challenges with health data, whether it is simply how many cases we have on a given day in a given location, where outbreaks are occurring, what's happening in our schools, how many people are in hospital or on ventilators due to COVID versus with COVID. We can have those kinds of questions. How many people are dying of COVID in a timely manner? We have had many, many critical data gaps. One headline that's particularly telling is to look at this one in French, but you don't need to be Francophone to understand what the headline is referring to. And the fact is, we continue to use fax machines as a means of transmitting health information in many settings in many parts of this country. And I think that speaks in a nutshell to some of the challenges we face. But the real question is, given all the investments that we've made in healthcare and in health systems, why do we continue to fail to develop a robust health data infrastructure? Before I get to some of our analysis around that question, I do want to highlight a few examples of where we sit relative to the rest of the world. On this slide, I know it's quite busy, but what we're showing is how in Israel, with they're integrated health systems with health maintenance organizations that cover defined populations that have a comprehensive set of data on each individual. They were able to do things like generate data, real world data on the effectiveness of the COVID-19 vaccines within weeks of the rollout of their immunization campaign. In fact, these slides, these graphics are from a New England Journal of Medicine paper that was published, as you can see, on February 25th, 2021, literally weeks after the start of the campaign, and was able to show, again, you don't need to be a statistician to see the diverging survival curves here and the tremendous impact that the vaccines provided. And we can recall that this was one of the things that Israel was able to commit to providing in exchange for early access to the COVID-19 vaccines. Now, this is not a simple exercise. In order to calculate vaccine effectiveness in the real world in this way, we need to bring together at the person level data on who's been vaccinated, who's at COVID-19 from lab data, vaccine data from public health or immunization records. We need to bring together data on who's been hospitalized, who's had severe disease, and we want to get mortality data. So these are all different streams of data that we have to be able to integrate quickly. Now, we are able to do that in some jurisdictions, in some settings in the country, but even the first studies that we were able to do were months after the start of the immunization campaign, as opposed to weeks. But more significantly, if we want to answer the questions that we faced at a country in the real time of the pandemic, we need to be able to have robust analysis that has significant power, that is sample size. And so being able to combine data across jurisdictions becomes really important. And we had very critical questions. For example, you can recall that Canada lengthened the dose interval. And so we wanted to know how well we were doing with the lengthened dose interval. And so we need to be able to look at people by age and by comorbidity to be able to analyze that. And we, in order to get to those specific subgroups, we need very large sample sizes, which would involve bringing data together across multiple jurisdictions. This example illustrates another critical issue for Canada. And it's, again, a very complex slide from a paper published last summer, but it shows the time intervals between collection and submission of specimens to and sequencing to when the data were uploaded to the international file sharing site, CIGI. And these are countries along the x-axis here, and we're showing the time intervals that we took. So over here, United Kingdom was very fast. So it's not the fact that more variants emerge in the UK. They're able to analyze their data much faster. And so within a matter of 10 days or so on median, they were getting data up and into the banks. You can see Canada's way down over here with the circle. On the lower part here, we're showing how many sequences were being submitted. And, Canada was actually a leader in sequencing. So we had lots of capacity to generate the data, but we were a laggard. Our median time early in 2021 was on the order of 80 days to getting those sequences up. And when we get into this, it's, again, not about the data being available. It's about the data being shared across jurisdictions, between labs and research groups, and between various settings. And so these are examples of where we may have the data, but we're not able to pull it together in a meaningful way. And at the same time, there is urgency because the countries that did well continue to develop strategies to do even better. Examples from the UK and the Netherlands. The United States, which is by no means a leader in sharing of data or in their management of the COVID-19 pandemic is also moving to get forward, for example, with their trusted exchange framework for sharing of data. We do have some good foundations laid, and we have great organizations such as CIGI and CADIF and Infoway, as well as great work being done across the country in provinces and territories and in jurisdictions. We just need to figure out how to bring this together in a meaningful way. What is very positive is that there is certainly growing momentum particularly from the experiences we've had during the pandemic to move forward on this, including in the speech from the throne, minister's mandate letter, and I think we'll be hearing from the minister very shortly, and most recently in the supply and confidence agreement between the Liberals and the NDP on working with provinces and territories to deliver better data, amongst other things, for the health system. So we think the time is right for some action on this. So where are we now? You know, we have multiple silos. We've been building scaffolding to try to connect the data across the silos, but it does result in duplication, in increased costs, both for development of systems and ongoing maintenance of the systems. And interestingly, even though many times the concerns that are cited for not sharing data are around privacy, our existing systems and the way they're organized with the silos and so on actually sometimes increase privacy risks, particularly because some of our systems are operating on antiquated operating structures where there's less ability to fend off the most current cybersecurity threats. And we've seen a number of significant breaches in the health system in recent years. So as a result, we are not getting the outcomes that we deserve, and we're hampering research, innovation, public health, and all the other things that we should really be using data to benefit Canadians. As I said, there are many pockets of excellence, but we've not been able to spread and scale what we're doing across the country. How did we get to where we are at? So we really have to think about the fact that our health policy, and particular health data policy environment, continues to be what we designed for an analog age. I won't say when I went to medical school, but it was before 1989. When I was a medical student and we wanted to get a patient's medical records, it was usually in the hospital, and we went down to the medical records department, usually in the basement, and we checked out the records from literally a health information custodian. And we could look at the record. We may have access to information from other settings if it's been mailed in, but most likely we would not have access to information from other settings. There was very limited access for individual patients and families to their own data. They would also have to travel to the medical records department and usually fill out lots of forms to get at it. And providers couldn't really look across settings. And so doing any kind of population level work, whether it's public health, health services management, or research, was very challenging. You have to bring data together from many different settings. And so that analog policy environment was developed for that analog data environment. And where we're at today is we continue to have an analog policy environment as we have digitized data. Now, digitization can mean a number of things, from fully digitized electronic medical and health records to faxes or PDFs of paper documents, but increasingly they are available in some digital form and can move around in ways that weren't imagined in that analog environment. But we still have an analog policy environment with custodians of these now digitized records. So patient access has become somewhat better, but usually it means having to access multiple portals with multiple providers as opposed to having access to all of one's information. And similarly, provider access has started to become better. But again, it's rarely that a provider can have access to all of their patients' information in close to real time. And if they can, it usually involves, again, navigating multiple different systems. So the future state we want to imagine is one where we have a digital policy environment for a truly digital system. And we think that means starting with a person-centered system that would enable the things that we want to do. And by person-centered learning health system, we simply mean let's put people at the center of everything we do. And not just, I would actually say, not just in terms of health data system design. If we design our health systems around the people we're providing the services for, I think we will have health data systems designed in that way. And we will also have data generated in the systems that will be able to be used not only for better patient care, so that providers have access to their patients' data in real time across different settings, but because the data will be structured in that way, it will be available for sharing for all the different purposes we would like to see. So in our first report, I won't go through this list. We went through 60 years worth of reports of why we failed to succeed at this exercise. And you'll see listed here the repeated sorts of things that have come up. And so in moving forward, we really need to think about how we overcome these challenges. And the critical thing I'll say is what we're dealing with is a policy challenge, not a technical challenge. The technical solutions to building our health information systems are there. But what we really need to work on, and we have these key areas: engagement of the public, building trust with the public. And in order to do that, we have to support data literacy with the public, with providers, with administrators, with policymakers, right across the system. And if we engage the public, we can then have the conversations, the meaningful conversations we have to have about how they would like to see their data used, how they like to see it shared, how they want things improved. We need to ensure we have the policy framework that is modern, that's effective, and that's equitable. It enables us to get the data that we need for the people that we need. And most significantly, we need clear and accountable data governance. And that's why we're so pleased to be partnering with CIGI on this topic, because they obviously have great expertise in this area and looking at innovations in governance. And as I said, issues of data interoperability, architect of the technical things can be solved if we have these other mechanisms in place. Another key area that we identify is moving to a culture of data stewardship from our current culture of custodianship. And what this means is thinking about our roles, various roles that individuals have in the health system, clearly need to protect the privacy and confidentiality of data, but individuals should also be held to ensuring that data are used in appropriate ways. And that is stewardship, that ensuring that we protect the data, but also make it available, and building that into the requirements for data stewards, which would really be transformed roles for privacy officers. And that's a major policy direction that we need to take. And perhaps most critical to success is going to be treating this as a collective action problem. We can't hand the exercise to one organization or entity to try to solve, because it requires all levels of government, provider groups, health services delivery organizations, standard-setting bodies, professional associations, as well as communities, and in particular, working with First Nations, Inuit, and Métis governance bodies. We have to all come together to work towards a common purpose. And there's lots of literature out there on how we solve collective action problems. and we need to learn from that and act on it. And with that, we can work towards a learning health system. So look forward to discussions. Thank you. Okay, so I see a question in the chat, sorry. Trust is the key outcome. Is data use in the public interest? Rigorous ethics oversight is needed to inform the average person that doesn't have a PhD to sort this stuff out. So a very important point, and that's why we've highlighted data literacy. And we know we don't have to have people have PhDs, but we need to ensure that people have an understanding of how data are being collected, how they're being used, and what different terms mean. And in building trust, we need to look at, for example, tools like citizen assemblies, where we can work with communities to help them come up to speed on some of these topics and then engage them on the discussion. But this is not an easy exercise. It is something that we have to work together with communities, and we also have to work with the policymakers, with administrators on supporting them. So when I describe data stewards, right now, many people are put into roles of privacy officers. They may have legal training, they may have ethics training, but they're not really supported in fulfilling their functions and meeting the requirements that they have to meet. And so this will require work across many different sectors in order to enable it. Okay, so we do have another comment regarding Indigenous ways of knowing, and certainly absolutely agree with that. So we will have a number of recommendations around how we can all work in the most effective and engaged way with First Nations, Inuit, and Métis communities. And maybe final question, can we hear more about the stewardship approach to data? And so, at a conceptual level, this is about having people who we've traditionally thought of as custodians of data be stewards of data. And as stewards of data, they have not only a responsibility for protecting data, but also working with other stewards of data and other users, whether they're in the public health community, health services community, or research, of making data available and accessible. And so have a positive mandate to deliver on those functions which can benefit Canadians. And that should be built into the legislative requirements for those roles. And we should be supporting those individuals in achieving those activities. Thank you very much, everyone.